Hey everyone, I'm going to record your lecture for your anti-epileptic drugs or AEDs. Your anti-epileptic drugs can be found in your Pearson and your Karch. In Karch, there's a couple of tables to look at. The whole purpose of anti-epileptics is to increase your seizure threshold. Everybody has a seizure threshold. They want to bring that threshold higher to decrease the risk of having seizures. As we get into them, when I do the next lecture on nutrition, I will talk more about a lot of the nutritional issues when they're on anti-epileptics, because anti-epileptics can obstruct a lot of absorption or use up a lot of the vitamins, which I will explain as I get into them, because that will make more sense for you. Table 23.1 in Karch talks about the hydantoins. Want you to focus on fosphenytoin and phenytoin, which is Dilantin. There's also PDF, and I have some slides talking about phenytoin. Fosphenytoin is given, can also be given intravenously during a seizure epilepticus, and it can be given faster because it is not phenytoin, but the body, when it's metabolized, breaks down into or converts to a phenytoin about 15 minutes after administration. Because phenytoin, when given IV, has to be given very, very slowly. It causes hypotension and can cause arrhythmias. That's when fosphenytoin may be more beneficial, because you can give it 3 times faster without that significant risk. But either drug being given IV, the patient is always on a cardiac and blood pressure monitor. And we'll talk about the other drugs that go into them. Just keep in mind that catabolism, the burning of your energy, is accelerated during a seizure, and they use up a lot of the nutrients. Okay, status epilepticus. I'll talk a little later. Airway, breathing, circulation, your ABCs, IV dextrose if it's appropriate, diazepam, lorazepam are things to keep in mind that you will be giving, and I will talk about more. I'm not going to go into children. Hydantoins, which I told you are in the chart in your Karch book, and I think it talks about a little bit in your Pearson book. Phenytoin is the one that's most common, but be familiar with hydantoins. I said there is a PDF attached for phenytoin. Phenytoin may be preferred. Although no anti-epileptic is safe during pregnancy, if they have to give one, that's the one they may choose to do. You cannot have any alcohol when you're on hydantoin. Therapeutic levels 10 to 20. Do learn your therapeutic levels. Your Dilantin will be listed in your lab as a phenytoin level. It's decreased dose in liver and renal function. Obviously, when anybody's on phenytoin, you're monitoring their therapeutic level and their liver and renal function. It's considered a contraindication in pregnancy and lactation, but they have to risk-benefit has to be weighed. Seizure activity does increase during pregnancy, so it may be necessary because of hypoxia related to seizures during pregnancy. Many adverse effects along with hydantoins, including decreased bone marrow suppression, so they can have some blood dyscrasias, so they need to report if they're having bleeding gums, bruising, fever, fatigue, tiredness, CNS depression, so you're looking for depression, confusion, drowsiness, lethargy, fatigue. Also can cause constipation, dry mouth, anorexia. Even not given IV, there can be cardiac arrhythmias, and hypotension may lead to urinary tension, a loss of libido, and I mentioned monitoring the bone marrow and your liver levels. There's some other megaloblastic anemia. There's a folate deficiency, and I will talk more about the vitamins in the next lecture. Hyperglycemia, because of decreased insulin secretion. So, of course, that's on anybody. Glycosuria, so glucose in the urine, So more so in your diabetic, where you're having to watch the glucose level even closer because they may have to increase some of their medications. Definite interaction with, I think I mentioned, with alcohol. Tetragenic effects, I mentioned, lots and lots of drug interactions with phenytoin. Increased levels or effect of the phenytoin if it's taken with cimetidine and sulfonamides. The decreased phenytoin effect if it's taken with folic acid, antacids, calcium, sulforaphane, antineoplastics, antipsychotics, and definitely with the herbs ginkgo and primrose. Decreased phenytoin decreases the effects of anticoagulants, antihistamines, dopamine, theophylline, and oral contraceptives. So obviously part of your teaching is going to be using a barrier method plus some other birth control method because of the decreased effect of oral contraceptives and the risk of tetragenic effects with phenytoin in pregnancy. So lots of teaching, lots to keep in mind with drug interactions. So that's some things to keep in mind. Possible test questions. That's just a Dilantin Dialet 10 that may be a mnemonic to help you remember some things. Can move right in here into your, oh, wait a minute. I want to go back to here. Some nursing interventions with phenytoin. If it's liquid, you're going to shake the suspension well for 5 minutes. Monitor your serum drug levels. Safety, because of CNS depression. Risk with driving, what do you call it? Operating machinery. I talked about Irricons, herbs, alcohol. Never ever stop any anti-epileptic suddenly. It has to be tapered off. There's not on it for life. Just because they have epilepsy, if they're seizure free for 2 years, any anti-epileptic may be weaned down to see if they develop seizures. Anybody with seizures, the driving issue, it varies by state as to how long you have to be seizure free before they will let you have a driver's license or be able to drive. Because of the problems with hyperplasia of the gums, they're going to have frequent oral care, frequent dental visits. Said diabetics, you're watching their drug level. Make sure any anti-epileptic they take the same time of day every day to keep therapeutic levels. Phenytoin can have a side effect of a harmless pink, red, or brown urine. That can be an expectation. I mentioned the bruising, nosebleed, also reporting sore throat because of some bone marrow suppression. They should wear a medical alert bracelet. I think I covered everything else when it comes to that. Okay, so let's go on to your phenobarbital. Phenobarbital is the only barbiturate that we're going to consider when we're talking about seizures. Therapeutic level for phenobarbital is 20 to 40. Learn your therapeutic levels. There is a PDF attached for you on phenobarbital. Is that the one? I think the phenobarbital is the one I messed up. No, I'm thinking of something else. So there is a PDF attached. Again, the CNS depression is much more depressing on the CNS system than the phenytoins, so phenytoins may be preferred. Phenobarbital can also be used for a lot of psychotic disorders. Again, never discontinued abruptly. Go into your benzodiazepines. Don't worry about clonazepam on the slide. You're going to focus on your diazepam. And just be familiar with your benzodiazepines and side effects of benzodiazepines, because the benzodiazepines that are used most often with seizures, clonazepam on certain seizures, we're going to focus on diazepam, midazolam, which is your Versed, and your lorazepam, or known as Ativan. Those are ones you will see more with the status epilepticus. So we're focusing on your benzodiazepines for seizures. It stabilizes the nerve membranes throughout the central nervous system to decrease excitability and hyperexcitability. And I said your clonazepam can be used with petit mal seizures, but you can develop a tolerance after a while for being on clonazepam. Your diazepam, as far as seizures, is used with your status epilepticus, and during that time it will be given IV. Also, diazepam does come in a rectal form or rectal suppository, so if you don't have IV access, they may give it per rectum. It is short acting, so it'll have to be repeated after a couple hours. It has to be given very, very slow. It causes hypotension and arrhythmias. It has the same contraindications and cautions that I talked about with your hydantoins, and they can develop a tolerance. Carbamazepine, used for seizures. Therapeutic level is 5 to 12. So if you get familiar with Tegretol in your head, your lab value is going to be under carbamazepine. Grand mal and petit seizures, I have the picture of grapefruit on there. You cannot take it with grapefruit, because grapefruit, if taken at the same time with carbamazepine, can cause a toxic level of your carbamazepine. It is used to treat refractory seizures that aren't responding to other anticonvulsants. And it may be used in combination with other anticonvulsant drugs or AEDs. Carbamazepine is used for bipolar, trigeminal neuralgia, alcohol withdrawal. Here's just a little help that might help you as far as mnemonics on things to remember with your carbamazepine. Valproate, which people know as Depakote, know it as valproic acid. That's what your lab value will be under. The therapeutic range is 50 to 150. Again, know your therapeutic ranges. There is a PDF attached for you. It reduces abnormal electrical activity in the brain, and it can increase your GABA activity to inhibit that overreaction or your seizures. It's safe for above age 2. Watch for hepatotoxicity. Monitor the liver enzymes and your therapeutic levels. And it is used with extreme caution in people with liver disorders because it's metabolized in the liver and can cause some issues. Valproic acid can be used in manic bipolar, also for chronic migraines that are refractory to other things. Of course, contraindicated with a known allergy, caution where there's hepatic or renal impairment, and contraindicated with a pregnancy and lactation. Adverse effects can be liver toxicity and CNS depression. Drug-drug interaction with antibacterial sulfonamides and your thiazide diuretics. Just some information, anticonvulsants in pregnancy, because there's a 25% increase of epilepsy or seizures during pregnancy. This picture down here with the spina bifida, I'm sorry, some of that slide got messed up there, but spina bifida is what's called a NTD, or neural tube defect, which you will cover more when you take family nursing. I think we're calling out the combination of peds and OB next semester in the fall. But it's a neural tube defect, which is due to decreased folate level, or a deficiency in folic acid. That has to do with seizures and anticonvulsants, AEDs, which I will cover again in the nutrition slides. Okay, and hypoxia can occur during during a seizure, which is at risk for the pregnant mother and for the baby, the fetus. So again, risk benefit outweighing each other as far as taking any anticonvulsant during pregnancy and the risk of the tetragenic effects. Monitor your phenytoin levels closely during pregnancy because seizures tend to become more frequent due to the increased metabolic rate in the body. Okay, status epilepticus. It's a continuous seizure greater than 30 minutes. It is a medical emergency. So I drew your little emergency guy down here. Airway, airway, airway. Never stick anything in the mouth when a seizure is started. So airway, breathing, circulation, neurological. A, B, C, D. A, B, C, D. D is disability. So make sure they have an airway, that they're breathing, that they're circulating okay, and watching for neurological. So you're going to keep them safe from themselves. If you have or can get a venous access, you will give lorazepam. IO is intraosseous. Anyway, it's giving in the bone if you don't have IV access. Lorazepam is the preference if you can give it because it's, one, not as sedating when you're looking at your neurological effect and it lasts like 4 to 6 hours versus when you're giving the diazepam or Valium IV, which may be what you give first. It has a shorter effect. Your Valium can also, I said earlier, can be given rectal. Midazolam, which I know is Versed, can be buccal, which dissolves in the mouth if you don't have any other access, or that's when you will give that. But lorazepam, diazepam are your preferences. If seizure continues 10 minutes after you've given one of those drugs, you give another dose of lorazepam, and you start getting your other drugs ready. Your phenytoin is what usually is given IV during your status epilepticus. It's also given IV. I mentioned earlier you can't give it very fast. You're watching for hypotension and cardiac arrhythmias. You have them on a continuous monitor for blood pressure and heart. Keep those in mind. If you have phenytoin available, you can give it 3 times faster than your phenytoin because it converts in the body after 8 to 15 minutes into phenytoin. So if that's an option, that is a preference. Let's see, senior help and anesthesia may be there because you may need an airway. Also putting them down, like putting them on propofol drip to keep them sedated and safe. Again, I'm not really going to go into the children, so that will finish this lecture on your anti-epileptic, anti-seizure drugs.